Welcome to the GIE Author Interview Series. I'm Dr. Glenn Eisen, the Editor-in-Chief of Gastrointestinal Endoscopy. I'm with Dr. Oleh Haluszka, who is an Associate Professor of Medicine and the Director of Endoscopy at the Fox Chase Cancer Center. Today we're going to discuss his paper, which has been accepted to GIE, Double Balloon Enteroscopy in the Elderly, Safety Findings, Diagnostic and Therapeutic Success. Dr. Haluszka.
Thanks, Glenn.
Well, welcome. Can you tell me the impetus for looking at utilizing double balloon in the elderly versus the non-elderly?
It actually was prompted by numerous phone calls I got. Because we're an open access referral center, I'd often get phone calls from referring physicians asking me what to do in a particular case. And then they would say, oh, by the way, the patient's 85. Do you think they would actually be able to tolerate a double balloon exam? So dealing with that kind of phone call on the numerous basis is what prompted us to look at our data on that group.
Did you have any trepidations about evaluating these patients?
No, because we'd had a pretty broad experience with them. So our anecdotal idea was that they actually did quite well, and this just gave us some more data to respond to the physicians.
Okay. How long has your group been doing double balloon?
We started in the late fall of 2004, so it was not long after it got FDA approval in the US. We were one of the first sites to start doing it.
Okay. And what did you find in the study? Are there significant differences in the safety first for the elderly versus non-elderly?
Actually, the nice thing was that there was no difference in terms of the safety with this. We actually, in the study, we had 170 patients, 60 were elderly, 110 were non-elderly, that we classified as under the age of 75. We had no complications at all in the elderly group. And the nice thing was that we were also able to show that you could proceed and get the same extent of exam in both groups. So you could evaluate as much of the small intestine in both groups. The interesting thing was, so when we looked at the results, we found that in the elderly group, we were more likely to do a therapeutic procedure, almost 1.5 times higher likelihood of doing that, excuse me, and that's predominantly because we found more angioectasias in that group. So oftentimes people call me with the thought that the patient hasn't had a capsule endoscopy. In Pennsylvania, where I practice, you can't do capsule on an inpatient and get it reimbursed.
Really?
So oftentimes the patient comes in, and now knowing our data with the elderly, I don't require a capsule endoscopy in that group at all, because we had found poor correlation between capsule and double balloon. Plus, we were just so likely to encounter AVMs that required endoscopic therapy. Just made sense to go ahead and proceed with a double balloon exam.
Okay, so I think your practice might be a little different than others, including my own, where we generally require doing a capsule first to make sure there's something to go after. I know that double balloon is sometimes technically difficult and onerous as far as how long it takes.
Right.
Now, you said that your policy now for the elderly is you don't require a video capsule first because you're frequently going to have findings that you may actually treat. Is that your broad policy for everyone? If you have a 40-year-old, given that you may have a lower likelihood of findings, would you still proceed initially with a double balloon?
Yeah, well, we don't do our own capsule endoscopy, so we require on capsule coming in from the physician who does it. If they have it, great, or some other kind of imaging study so that we have a target to go after. But I found that, for us, our average time of doing a double balloon exam is right around 70 minutes or so. And typically what we can do is in those patients where there's a pretty good likelihood that we're going to find something, or we need to rule out the finding, we'll often do an upper double balloon exam, tattoo the distal extent of the procedure, and then bring them back for a subsequent procedure to do a lower double balloon so they have completed a complete enteroscopy.
Right. And in your group's hands doing both antegrade and retrograde exams, what fraction have pan-enteroscopy where you're actually able to reach that tattoo site from a retrograde approach?
It depends on how badly we need to do it.
Okay.
Because again, we will limit the exams based on time. So our typical procedure is to start off from above and to proceed going distally as far as we can for about 90 minutes if we haven't found the lesion. So in that time, we find that we can, in patients who haven't had a prior operation, get to the proximal to mid-ilium. And in that group, if we need to bring them back, I think there is a pretty high likelihood that we can find our tattoo.
Okay. Now, in the elderly, you very frequently find AVMs.
Right.
Do you equate the finding of AVMs with making the ultimate diagnosis and changing the outcome in the elderly?
Well, we haven't looked specifically at outcomes in this, but we, find that we are treating these patients more. Again, from an anecdotal basis, I find that patients that we've treated, occasionally we do need to see them back, but what we found is that generally their transfusion requirements have gone down. We don't need to see them back quite so often, but they do tend to come back because, again, in that group, we found that many of these patients are either on anticoagulants, antiplatelet therapy. An interesting finding from the study is that the rate of angioectasias almost exactly correlates with the rate of coronary artery disease in these patients. So they're patients that are likely to have either recurrent lesions or lesions that may have been missed.
Just as a matter of practice, if hypothetically you had a patient that had 1 or 2 angioectasias and you ablated them, would you feel it necessary to do pan-enteroscopy to look for other potential lesions?
No, we'll kind of go over that with the referring physician, follow them clinically. Surprisingly, I've had a number of patients with a single angioectasia that we've treated and their bleeding has gone away. So I think the typical thinking had been that patients have multiple ones, but I've found a number of patients with a single AVM that you can treat,
changes their outcome.
and it does change the outcome.
I must admit, just in my practice, I've been skeptical of people that have a single AVM, and sometimes we're not even sure if it's an AVM versus a red spot.
Right.
I think one important issue for our readers that I want you to talk about is the issue that how safe your data is, how well the patients did. But you're clearly an expert referral center. You've been doing this for 5 years. You have large numbers. Many practitioners are just starting this, and they may not necessarily get the same results as far as diagnostic efficacy or safety.
Right, and that's an important point with any endoscopic procedure. There's always got to be a difference between the expert centers and the people who may do a number of just small number of exams. The other thing that I think is useful for us is that we tend to use carbon dioxide insufflation, which has been shown in some studies to limit the discomfort, and I think may actually have a role in allowing us to proceed further distally during the extent of the examination.
Okay. Do you have any final take-home points for our readers?
No, I think the readers should realize that double balloon enteroscopy is here to stay. It's a very safe procedure for the majority of patients, and I think there's a good likelihood that we can do therapeutics that will impact the clinical course of our patients.
Thank you very much, Dr. Haluszka.
Thank you.